So welcome to our Healthier Together Lunch and Learn, focusing on coughs, colds and everything in between. I'm Laura Cassidy, I'm the Network Delivery Manager for the Child Health and Wellbeing Network for the North East North Cumbria and lead on the Healthier Together website and mobile app. And I've got Dr. Emma Lim, who is going to be delivering the session. What we'll start with, and she'll introduce herself fully when she takes over, I'm just going to give you a quick introduction to the network and the work that we do and some of the background context to Healthier Together, and then Emma will lead on with the clinical aspect of the session. So just from a network perspective, a lot of the work we do is around reducing health inequalities for children and young people and aiming to improve health outcomes. The Healthier Together work is very much driven by our high rates of A&E attendances for children and young people, not just for 0 to 4-year-olds, but 0 to 18-year-olds, and we have the actual highest rate in the country. So it's really about supporting parents with the information and to be able to make informed choices around their child's health. Obviously exacerbated by that, which I'm sure you'll all be aware, is the level and challenges that we have around child poverty in our region. And a lot of the work that we do is about that collaborative approaches, so the whole point of our lunch and learns and the models that we do around our Healthier Together champions is about ensuring voluntary sector organisations, schools, other clinical health professionals working out with families is aware of the resource and being able to support parents to access that. So it's very much about maximising reach into those communities where they need it most. From a network perspective, we believe all children and young people should be given the opportunity to flourish and reach their full potential and be advantaged by organisations working together. And a lot of the work we do is about collaborative work. And you can see on the right there that's our priority wheel, and young people and children's voices is pivotal to that. And alongside our strategic oversight group, we have our youth voice group running in parallel who support the work of the network, but also give us that voice and they work and reach out to wider youth groups across the region. Main part of some of the areas that we deliver on is that children and young people's transformation programme, and this is about leading change and system improvement, very much about ensuring inclusive service delivery, and you can see there, and a lot of the work that we do is driving work around asthma, improving asthma outcomes and other long-term conditions like diabetes and epilepsy. So as I mentioned, children account for 25% of ED attendances, and actually we need to support the system with that, particularly as we're heading into winter with our healthcare pressures. And I know obviously we've seen an early rise in flu in children this year, so I think it's really crucial that we could get the information out to support parents as best we can. What parents tell us what they want to know, and the real reason that Healthier Together was developed is very much about when a child has this minor self-limiting illness and they can stay at home and self-care when safe to do so, but also when to go to hospital with those more serious illnesses. And actually what we don't want parents to do is delay presentation. So if a child's in a red category of symptoms, we want them to seek that urgent help. And obviously when they're in between that, visiting the GP or 111, and Healthier Together is obviously based on that red, amber, green rag. And we know for families that obviously this message can sometimes be confusing and complex as our systems change, service offers change, so it's really about ensuring that they've got the most up-to-date and recent information. So Healthier Together, we adopted it as a model of good practice, and we're part of a group nationally who is in the process, and you'll see there's been changes to our website, and we're moving to even more new and improved advanced version coming up soon. It won't affect how you use it. It's very much going to be that we're moving to one URL nationally, but behind that there will still be the local information that is down to our local area, but it will have a lot more new features and increase accessibility for our families. So target audience, from a website perspective, it's healthcare professionals. There's lots of standardised guidance, and that'll be some of the things that Emma will cover. And obviously there's that information for parents and carers, and they run in parallel to each other and very much in a link that parents can access the professional section, and obviously the parental information is there as an important safety net and tool. And some of those safety net and features around standard format, the red, amber, green, and our SMS share functionality, which just shows you at the top that you can send text messages at any time from the website or utilise the app to send parents home with the information. So I'm going to stop there and I'm going to hand you over to, I don't know why it's jumped. so far away. Sorry, 2 seconds. I don't know why that's gone.
You've got my slides.
Yeah,
Laura.
I've got your slides, but I don't know why it's gone to. It's jumping back to them too. Sorry, apologies.
While you're doing that, I'll
Yeah.
just introduce myself. I'm sure some of you, or many of you, will know me. My name's Emma Lim. I'm a general paediatric consultant at the Great North Children's Hospital, and I also do some paediatric infectious disease. And hopefully Laura has got...
Yeah, no, they're there. It's just for some reason. There we go. I don't know why it was doing that. It was popping back the other way when I was trying to click it forward. Apologies.
And the co-clinical leads for this is myself and Alex. And I wanted to make this really practical today. And so we thought we'd put some case studies in of things that we see all the time. And this season has started. Everybody, and I'm sure you as well as us, are coughing and sneezing. So our first case study is a 4-month-old girl who's come in with her mum, so a little baby, with 3 days of a runny nose and a cough. And just today, she's had increased worsening of her breathing, and she's breathing faster than normal. And she's not feeding as much, 5 ounces since this morning. She's not vomiting, but she's got slightly reduced wet nappies and possibly had a temperature at home. Mum thinks of 38. In her past medical history, she was born at term. She's up to date with her immunizations. And when you have a look at her, she's really coughing, she's snotty, but she's alert, warm to touch, and has a normal capillary refill. But she does have mild increased work of breathing, so a bit of subcostal recession. And when you listen to her chest, you can hear wheezes and crackles, but no stridor. And everything else is normal. Can we have the next slide? So you're sitting there in your practice, and this is just the kind of patient you're seeing all the time. And it's really easy if you go on the Healthier Together website and you look under the professional sections to look up the professional guidelines. And this obviously is a child who has a bit of cough and breathlessness, but they're under 1. So this is the one to look up. And you can see it tells you exactly what to do. So green, low risk, would be we'll start from red. So at the red side, these are the patients who you're going to want to send straight to the emergency department. And I'm sure you know all this. So a child who's grunting, a child whose respiratory rate is over 70, and our patients isn't, or who's in severe respiratory distress, or obviously having apneas, or audible stridor. Any child with markedly reduced fluid intake, and we would say less than 50% of their normal intake over the last 2 or 3 feeds. So her feeding is down, but it's not less than half. Look at the colour. We said she was normal colour, but a child who was blue or grey or unrousable, or the very young children, so under 3 months with a temperature of 38, they would all go straight to ED. So our child is not in that category. Sometimes you won't remember what's normal, and we actually have a set of normal values that you can check on the professional section. So our child has a respiratory rate of between 50 and 70 and mild respiratory distress, no stridor. Everything else is okay. She's a little bit, her feeds are down, but she's not dehydrated. She doesn't have risk factors, so she is over 3 months, but her temperature is not over 39. She's not had more than 5 days of fever. She's not a premature, and there are no obvious red flags. So this is a kind of grey case you see all the time, and I would ask the parents how confident they are. So if this is somebody's 2nd or 3rd child, and they felt confident and not worried that they would cope at home, I would send them the parent information, send them home, but make sure they know where and when to go to ED. So go through the red flags with them. On the other hand, if this was a first-time parent and they were worried that the child was going to get worse, it was already in the evening, so if they're going to get worse, it might be night, I potentially would send them up to the emergency department. So there's no absolute right or wrong, but this is a way to help yourself decide which category to put the child in. Next slide. So, of course, this is no surprise we're going to talk about bronchiolitis, and our case had bronchiolitis. And I'm going to go through the good, the bad, and the ugly. So the good news is we have a lot of information on our website. So we've not only got parental information, and some of the information is really basic information. I find the thing that I need to explain most is if you have bronchiolitis, it's a 10-day illness. So you're going to get worse for 5 days, and then for the next 5 days, you'll get better. But you often have a post-bronchiolitic cough that can carry on for 2 weeks. So you want to talk to the parents about this, because otherwise they keep coming back saying, guess what? They're still coughing. Give me antibiotics. It's really important to explain it's a virus. And so antibiotics is not going to make any difference. In fact, it may cause harm because it's a small baby. We want them to have a good microbiome. We want to not give antibiotics unless we really need it. So going through that with the parents, I found really helpful. And then I would usually go through the safety netting with them. So I would take them through the red symptoms, and I would see these are things I'd really worry about. If you have these, you go straight to the emergency department. If your baby's worse, but you're not sure, then you can contact your GP via the app or 111, and I would go through those. And then I always say to them, if you're going to go home, it doesn't mean your baby is well, but it means your baby is safe to go home. They're unwell, but it's not serious. And that's the green section. And we have a whole lot of self-care. So that would go through giving them small, frequent feeds, monitoring their temperature, whether you give paracetamol, etc., etc. So that's how I use it. And I think it's really helpful. And it empowers parents to go home and not worry so much, and know when to get help if they need it. Next slide. So our bronchiolitis pathway looks very similar to the cough and cold under one. But what we've added, this is obviously if you know it's bronchiolitis or that's what you think it is. When you look at these pathways, you'll see we've got something to remind you about the clinical assessment, what you need to ask about, the risk factors. So these are the specific things you're going to ask. You're going to check the baby's not premature. You're going to check that they don't have underlying neuromuscular weakness. I always worry about reattenders, so they would be a risk factor. If it's their second attendance, I would be much more likely to send them to the emergency department. Any pre-existing lung conditions, so ex-prems. I mean, they're only 4 months old, so that's the real one. Any heart disease, any immunodeficiency. And did you see the bit that says vital sign values? That leads you to the page with the normal parameters for respiratory rate, oxygen, etc. And the red flags are the things that you would immediately send them up. So these are all really similar in a bit more detail if you think it's bronchiolitis. Next. So you've made this diagnosis of bronchiolitis and you're like, oh my goodness, is there anything new in the way of treatment and management? Because really, bronchiolitis is something, it's a viral condition, it gets better by itself, but it takes time and it causes a lot of anxiety. So we did a quick literature search to see what we would find. And you can see there's 887 pages of information and new studies about bronchiolitis, but next page, there is no real good treatments. So the treatment is exactly what you know, it's just supportive. So if their saturations are fine, they don't need anything. Obviously, if they have low saturations, they need admission. We've had a lot of discussion about what we call low. In the hospital, I don't worry about anything down to 90%. because that is actually not a problem. I do appreciate in primary care, you've got to be more conservative. So we usually say 92%. And then you've got to think, how do you deliver this oxygen? Is it just by nasal cannula, or are you going to put them on high flow? Or actually, are they so unwell they need PICU and they need more active ventilatory support? Then you need to support their feeding. So just like I say, basic things, little and often. If they can't feed because they're so breathless, and this can happen particularly with breastfed babies, think about putting an NG tube down. And if they're really, really unwell and you're trying to avoid an ITU mission, you might put up IV fluids. But time is the great healer. They will get themselves better, and good safety netting advice, as we've just had a look at. Next. So this is very exciting. We were hoping that we wouldn't give this talk because we were hoping that RSV vaccination would change everything. And it certainly has in other countries. So we know that it has been introduced in Australia and the States. And the aim of the RSV immunization program is to lower the incidence and severity of RSV, lower respiratory tract infections. So you're not going to stop everybody getting infected. They're going to get the infection, but you're hoping that it will be a much more mild disease. You'll have less admissions and less intensive care admissions. So that is your aim. It's not eradication. It's just to make sure they don't get that serious, severe disease. And how are we going to do that? So there was a lot of debate about this, but we're going to protect infants through maternal vaccination. So we give the mothers, while they're pregnant, an active vaccination as part of their routine immunization schedule. So that started this year, which was really exciting. So they were supposed to start in August, September, so that they would all be protected and no pregnant mothers would give birth to, no unimmunized mothers would give birth to children who get RSV this winter. But we know the coverage hasn't been very good. So we are getting admissions, and all the admissions and the children who go up to intensive care are from unimmunized mums. And I think there was a bit of reticence from the mothers to get another vaccination. So we'll have to just cross our fingers for next year and encourage pregnant mothers to take up this vaccination. Now, there's another way we can help, and that is with extremely premature infants, or infants and children who are really high risk. So those that have congenital heart disease or immunodeficiencies, and that is through selective immunization. And this is the administration of a monoclonal antibody. So you just pick the high risk group and then we immunize them. The next slide. And this is very exciting because last year, you will all remember, and for many years before, we've been using palivizumab. But palivizumab means that they have to come every month to get a top up. So you're having monthly injections. So there is a new monoclonal antibody on the block. And this is, I always have trouble saying this, nirsevimab. So this is a humanized monoclonal antibody, and it provides passive immunization against RSV. And you just give it once before the RSV season. And this will be for your high-risk patients. So any ex-prems who have bronchopulmonary dysplasia, chronic lung disease, so the premature, infants who have respiratory diseases who remain in oxygen with pulmonary hyperplasia, congenital lung abnormalities, interstitial lung abnormalities, and those high risk with congenital heart disease, and children less than 2 years old with severe combined immunodeficiency. So I think this is just important because some of these children will be around in the community. You might have them on your books, and it's trying to remind these families that they need to go and get this. Next slide. The bad news is that nothing works. So I get absolutely crazed when these children come in, they're really snotty and they're really crackly. And before I know it, somebody has given them a neb just to see if it works. It doesn't. And because the neb didn't work, they then decided to give them a dose of steroids to see if that worked. And that doesn't work either. And then I find, because they've been unwell for a day or two, especially in the returnees, I find that people start to prescribe antibiotics. A long time ago, people were using hypertonic saline, but none of these make a difference. The only thing I would say about the antibiotics is, if you have a child who's had RSV bronchiolitis, so they've been unwell for 10 days, they've got better, the cough has gone, their temperature has settled, and then they get worse and start spiking a fever again, you can get secondary bacterial infections. But it's usually not this one illness, they've got better and then they've got worse again. So that's the only time. It's those representers that we said the reattenders are high risk. Next. So now we're down to the ugly. The zebras are, I don't know if you all remember that idea of, is it a horse or is it a zebra? So there are the rare weird things. So we're going to go have a quick look at those. And this is a question like, at this time of year, we see all these children coughing and wheezing and spluttering, and we tend to think they all have bronchiolitis, but some of them don't. So we're going to go through those things that should just trigger you and go, hey, that doesn't look the same. I think you've gone backwards, the wrong direction, Laura. Yes. So this is our next case. This is a child who always seems to be a bit breathless. So they come to the emergency department and everybody thinks they have a lower respiratory tract infections and laryngomalacia. So they've got a bit of floppy airway. And they've got worsening respiratory distress. So they're always a bit breathless, but they're worse now. They have significant intercostal and subcostal recession. And actually, when you talk to mum, it's not just these last few days. Over the last 2 or 3 months, every time they feed, they stop in the middle of their feeds, have a little pant and start again. So they're breathless with wheezing and there's no wheeze. So immediately, if you were all in front of you, I'd make you say, what are the red flags? But the thing to think about here is the history is much longer. This child has red flags because they've got significant respiratory distress and it's getting worse. And it's a bit odd because they're not wheezing at all. So there's a few things in this history that look different. Next slide. So this child deserves to have an X-ray. Most of the time you do not need to do X-rays in children with bronchiolitis. And what strikes you here? The big thing that stands out is there's not much lung there, is there? Because there's a great big heart in the way. Next slide. So this, as I said, it was a longer history and there was no preceding coryzal symptoms. So that's very typical of bronchiolitis, that you start, you're a bit snotty, then you're coughing, and then you get respiratory distress. But this one, actually, they've been breathless all along and they're not more snotty at the moment. So these are key features to think about. So that one was congenital heart disease. A presentation, sorry, go back to that one because I realized I didn't put the last slide in. So this case, if you look at the chest x-ray, was a case of a child with worsening congenital heart disease. And actually every year we have a few children present in cardiac failure. If you go back, can you go back to the x-ray for me, Laura? Yeah. So every year at this time of year, we have a few children who present with cardiac failure with undiagnosed congenital heart disease. And this x-ray is a giveaway because you've got cardiomegaly. You've also got those sort of fluffy changes throughout the lung field. So it's not patchy, it's fluffy and it's throughout the lungs. And that's a sign of pulmonary edema. If you were to examine them, they might have a big liver and possibly they might have a murmur, but I'm not expecting anybody to find one. And you can see what happened to this child. They obviously got admitted. They couldn't feed. They needed a nasogastric tube down and they needed some diuretics and an urgent echo. So now we can go on. So the next case is The first case is twin. And this child has had 3 presentations of bronchiolitis, but it's different because his chest x-ray had changes on both occasions. And when he left, they were never completely right. So mum is always worried that this baby isn't thriving like his sister. And I think twins are a really good case because you've usually got one normal twin to compare to the other twin. When they've been in, their oxygen saturations are normal. So they've always felt that they were well enough to go home, but they've never been completely right. Next slide. Because you're very good pediatric doctors, nurses, GPs, so you always plot the weight. And there's a big red flag here. So when you look at this weight chart, this baby has crossed 1, 2, 3. They're down to crossing the 4th centile. So their weight has really plateaued. So there's something else going on. And this is much longer than just this acute illness. Now, this child has had a few blood tests. So they've had a hemoglobin, and you can see that hemoglobin is drifting down. So it was normal-ish, and it's gone down. Their platelets have always been normal. Now, this is a clue. Everybody looks at neutrophils. We always look at neutrophils. We always think, is this a bacterial infection? Have the neutrophils gone up? That's normal neutrophils every single time. So there's obviously a viral infection. But what happens is we always forget to look at the lymphocytes. We tend not to think that there's anything important in that. But this child has had low lymphocytes at birth, and actually they've gone right down, and now they're less than 0.1. So this, of course, is primary immunodeficiency. And these are often children with severe combined immunodeficiency. And these are the things that you need to look out for. Now, if you look up online, these are the kind of flags that we think about in general. So we know that normal children will have between 10 to 12 infections a year, and those are almost all viral. And I tell parents you're going to get 1 a month over the winter. So you're sick for a week, you're getting better for a week, you go to nursery for a week, and then you catch your next infection. But 8 or more new ear infections within a year would be unusual. 2 or more serious infections. And for serious infections, I usually say infections that mean you were admitted and needed IV antibiotics. Children who have 2 or more months on antibiotics with little effect. So when you give them an antibiotic, they don't get better. 2 or more episodes of pneumonia. Pneumonia is chest x-ray changes and requiring IV antibiotics, so serious chest infection. Failure to thrive, to gain weight or grow normally. Now that is an absolute red flag. Recurrent deep skin or organ abscesses. So we certainly see children who have 1 or more big abscesses. I don't mean skin pimples, I mean abscesses that need draining. A need for IV antibiotics to get better, persistent thrush in the mouth, or fungal infection on the skin. So babies are allowed thrush on their bottom. And they do occasionally get thrush in their mouth, but over 1, you shouldn't be getting thrush. 2 or more deep-seated infections, so sepsis, meningitis, and most importantly, a family history of primary immunodeficiency. And people sometimes don't know, so I say, has anybody had any problems with severe infections, or have anybody had babies who have died young and nobody knew why? So sometimes they won't know that they had an immunodeficiency. They'll say, oh, they died of meningitis or something like that. So you have to be careful about asking that question. Next slide. So the exciting news is Newcastle and our region is a pilot site for the newborn screening of severe combined immunodeficiency. And this has been really exciting because it means that we would identify it on the newborn blood spot. And that means that we would pick these babies up before they get sick. They would go on to prophylaxis, they would stay well, and then they would be well for their bone marrow transplants. So we've actually identified about, well, this is not just Newcastle, it's 3 regions outside the UK, and we certainly identified about 4 or 5 children with this already. And actually, compared to the late ones who present late, already sick, they have much better health outcomes. So they go through transplant much more easily. The red flags highlight the importance of pattern recognition. So looking for those things. Maternal concern and clear growth are always something that would worry me. So when the mother is worried and when a child is not growing. So in your differential, when you see these children who've got what appears to be respiratory distress, think about your differential. Look out for cardiac problems. So almost always they have a longer history. They almost always have problems feeding. They don't grow well, or they stop in the middle of their feeds to breathe. These children are often in respiratory distress, or they have a bit of recession, but they're not snotty. And that's something that you should look for. So in a child who's working hard to breathe, but not snotty, think about heart. Think, can I hear a murmur? Do they have a big liver? Can I feel the femorals? And are they a bit on the thin side? So cardiac, every year we get one of these. Immunodeficiency. In these children, again, there's a clue in the history. They don't have a typical course. They don't recover completely. Their growth falters. They might have other features, so skin abscesses, funny rashes, persistent thrush, or a family history. So look at their growth, think about their skin, any funny rashes that are not clearing up, and whether you've actually seen them last week and they're no better, and actually this has happened before. Finally, respiratory problems, underlying respiratory problems. Again, it's usually in the history. There's not a typical time pattern. A child with no crackles or wheezes and persistent unilateral signs. So that would be something we would worry about. And every year we see children who have a bit of bronchomalacia, so they are getting recurrent chest infections in one place. Next slide. So finally, what I just want to think about is every time we do this, we always say the same kind of things. Take a good history. All your clues are in the history. All right. Your examination will help you confirm what you found in the history. Think about the typical trajectory. Always share safety netting with parents, because if you're going to send the parents back home, make sure they know what to look out for if their child deteriorates, when they should go to hospital, and where they should go, because it's no use them suddenly getting worse and coming back to the GP. So you might say, if they're going to get worse in the next few days and you see red flag symptoms, go straight to ED. Next slide. Outcomes. So whenever I'm in the front of house in the emergency department, I find myself sending out the same safety netting advice again and again. I use fever or high temperatures, recurrent illnesses, bronchiolitis. Almost always these are the things that I send out to parents. And it's just a reminder, the new website works just as well as the old one. So you use that little, it looks like a little world. It's up on the top right-hand corner. And then you can text it to the parents. You can text, it is still got the translation function, but you tell parents, if I text you the link, you then have to turn on the translation and choose your language. So it works really well, but it won't text them in their own language. So it's just a reminder. Next slide. So our ask to you is, please put Healthier Together into your day-to-day practice. Use it, share it, use it for safety netting, use it to decide if you need to send somebody up to the emergency department. Think about making every contact count. So when you see a child with bronchiolitis, you might want to explore what's going on in that house. Are there a lot of kids in the house? Is it a damp house? Is there mold? Have they got, just recently this week, I've seen a child who's had recurrent respiratory infections. And actually, when I talked to mum, the problem was she was running out of money at the end of the month and couldn't afford formula. And so we could talk about getting vouchers for formula and help from the food bank. So think about all the things that go round that child and the other children. Obviously, we want you to get the parents to download this app, because remember, hopefully, if they look up bronchiolitis, they'll look up other things, and that means that they won't come back to you the next time they have eczema or vomiting, because they will have looked it up and know what to do. I can't say enough. It's a bit like Edison and the light bulb. If you don't tell everybody about brilliant thing you've got, it might as well be no use. So we have got to keep using social media, keep telling everybody, use Healthier Together, look at this. We have used it very successfully in schools. So in the opposite sense, we've done some work with schools, and they get a lot of absences in the winter, and a lot of parents will keep their children at home with a cold, which is obviously pointless. They might as well go to school. They caught the cold from school. That virus is already circulating around the school. So what some of our schools have done is that they will ring up the parents and they will say, what's wrong with your child? And if it's just a cold, they have a page of red, amber, green, and they'll say, actually, if a child doesn't have a temperature, if it's just a snotty nose, they can come to school. That is a green thing. So that has really helped improve attendance in various children. So we use it with the schools. We certainly use it in anything where there are I think you've got bronchiolitis, Laura.
No, I've got a cold. It's a cold.
It's just a cold. Okay, that
It's
means
just
you
a
can
cold.
come to work.
I'm at work. I've just got the daft tickly cough to go with it.
Yeah. So please promote it, use it, and think about how you can use it in a broader context.
And just the last plug there, I guess, from a practice perspective, obviously the Healthier Together app practices can onboard. It's free to use for the online consultation function. So we are trying to get as many practices to engage with that and offer parents that route into making an appointment. So if any practices are interested, it's a quick and easy process. We are seeing the numbers of practice on board and grow, and the number of children we've now got registered through the app is over 13,000. So we're trying to get as many children registered this winter to help families, but also to help yourselves with the pressures. And I think a quote from one of our GPs in Sunderland East, PCN, who's actually all of their practices have now onboarded, is actually very much about, it's that go-to tool for parents during the night when their child's unwell and they don't know what to do. So it gives them that kind of reassurance to know when it's safe to stay at home and when it's not really. And actually what we want to do is, not for parents to delay a presentation. If they are in the red, we want them to be seeing, Emma's team in ED. So it's really about just getting those key consistent messages out to our family. So I'm going to just stop there. I was also going
to say we've got some really nice data to show that the families in the GP practices where they're using the app, about 3/4, when the parents go on the app, about 3/4 of them are green, so they just need self-care advice. So they look that up and then they stay at home. The amber ones will be able to send a message to the GP practice. And of the messages the GPs get, they can look through and filter them. And a good proportion of those, they can just give them advice and then they stay at home. So actually, all of those might have taken up appointments and they didn't because they got advice. Very few actually end up being read through to the emergency department. But it is interesting. It definitely has reduced the number of, I wouldn't say unnecessary appointments, but appointments for very minor illness where they could get advice just by reading the right information. So I think we'll just take any questions.
Stop there, yeah. Has anybody got any questions? We always seem to go quiet on these sessions. It'd be great to have some interaction and some
Or if
hands
you
up.
don't feel like talking, please type something into the chat. Maybe if you take stop sharing and then type into the chat, and then we can read the questions.
No, I don't think nobody's started to type. So I'm assuming we haven't actually got any questions.
No questions at all.
No questions.
Does anybody want me to talk a little bit? The differential, the one thing that we find is the differential from bronchiolitis is recurrent viral-induced wheezing. If you want me to talk about that for a few minutes, type in the chat. Otherwise, I'll happily stop. Oh, there's one thumb up, so one person. So I think the one differential from bronchiolitis is viral-induced wheezing. So this is always, I mean, I did leave it off because I felt like we had enough to cover, and I thought we would cover it in our next one, which might be asthma and viral-induced wheezing. Oh, Suzanne, I'll answer your question in a minute. But viral-induced wheezing is almost always something that you can get in the history. And so it tends to be slightly older children, not the babies. And it tends to be that every time they get a cold, they start wheezing, but it's a fine wheeze. They're not extra snotty. They're not necessarily, they can cough more, and they almost always cough more at night than in the day. So in those children with viral-induced wheezing, so they're completely well, and then there's a pattern of every time they catch a cold, they start wheezing, the cough is worse at night. We sometimes give them a trial of salbutamol. And if they have salbutamol and inhaler and they say, yes, that makes a huge difference, then that's given you your diagnosis. Within the group of children with viral-induced wheeze, there are some who I call suspected asthma. Now, these children are under 5, so we wouldn't diagnose them as asthma because we can't do a pheno, we can't do lung function. But they're slightly different from the straightforward viral-induced wheeze. They usually have a family history of asthma. They may have eczema or allergies, and they have symptoms in between colds. So those families, when I ask them, they'll say, oh yeah, they wheeze and cough when they've got a cold, but actually, if I ask them to run around, they stop. The last one I said, he said, every time he runs around, he stops and put his arms on his legs and goes, so they're breathless. The other thing that they tend, so family history, symptoms in between colds, symptoms on exertion, and symptoms that, so they typically say things like, I went near a dog and I was wheezy, or I went from hot to cold and I noticed my child coughed more, or when we went on holiday and it was lovely and warm, nothing happened. So those children, when you give them salbutamol, they'll say it works brilliantly, but you'll find that they're using tons of salbutamol. So they're using salbutamol every time they have a cold. And if they're using it more than 2 or 3 times a week, those are the children who will benefit from Clenil, even though they're under 5. So that's my tips for viral-induced wheezing. It's history, and then thinking about the suspected asthma hiding in there. Are there any questions about viral-induced wheezing? Was that clear? I'm taking silence to be yes. Suzanne had a great question, which is, what age do you see primary immunodeficiency presenting up to? Now, this depends on the type of primary immunodeficiency. So your severe combined immunodeficiency, so this is the most severe, will present in their infancy, so very, very young. And those are the ones who may turn up like this. The children with more subtle primary immunodeficiency, so it might be a T cell defect or a B cell defect, they will present a bit later and they might present more subtly. So these are the children who are a bit older, who might just have recurrent abscesses, and you're like, why have they been in for IND 2 or 3 times? So they've needed incision and drainage more than once. They might be the older ones who you go, ooh, when you're doing your school screening, they're a bit skinny, and they've got some funny eczema rash. The typical one is funny eczema rashes that don't get better, whatever you put on them. So even if you've got steroids, antibiotics, whatever, they don't get better. So I'm always suspicious of failure to thrive, funny skin rashes. But those ones might present a bit later. You can actually present with things like chronic granulomatous disease right into the school age. But to be honest, it's all in the history. And think the most common things. When we talk about the family history, we know that some ethnic backgrounds have a much higher rate of cousin marriages. So, for example, we know in Pakistani families that's absolutely normal, that's culturally normal. And also in families from the Middle East, we know that first cousin marriages are the norm. So, that is something that always makes me worry. We also know that in Ireland, there's a smaller gene pool, and it's very easy for them to intermarry. So actually, they again have a lot of cousin marriages, and we know there are families there who have primary immunodeficiency. So we kind of know to anticipate that. So sometimes it's just saying, are you first cousins? I actually ask all my patients, but then of course I do infectious disease and immunology. So I do ask all my parents, are you related to each other? Are you cousins? Just occasionally that comes up as a clue. So thank you for those both great questions, Nita and Suzanne. Anything else? Oh, thank you very much. It's always nice. Suzanne said thank you. Always nice to be thanked.
I thank you everybody for attending, and we'll draw the session to a close. Please do, if you have any questions, and you can drop us an email, and we can pass them on to the clinicians, to Emma and Alex from a clinical need perspective around anything that's on Healthier Together, and look forward to seeing you on future sessions. Thank you.
And please put in what you'd like us to do next time. So any things that you want us to talk about, we want to respond to you. So any suggestions for future Lunch and Learn, pop them in the chat.